Welcome back to the deep dive. Today, we're really digging into the foundations of modern mental health support. It's quite a landscape.
It really is.
When you look at the materials we've pulled together, everything from brain chemistry basics to crisis response, even the philosophy behind care, it's clear you need to grasp biology, urgency, and the human element all together.
That's the goal today, isn't it? To kind of synthesize all that foundational knowledge. It's often taught in pieces, but we want to see how it connects.
Right.
What actually happens when stress just overwhelms someone? How do we use these powerful medications smartly? And maybe most importantly, how has our idea of what getting better actually means? How has that changed over time?
Okay, so it's a journey from the immediate emergency, that acute moment, all the way to the long-term view of recovery.
Exactly.
Well, let's start where the pressure is highest then. Understanding crisis and intervention, our sources define a crisis as temporary, right? Where someone's usual way of coping just stops working.
Yeah, that's a good way to put it. It's like their usual problem-solving toolkit is suddenly empty or overwhelmed.
Yeah.
A temporary loss of functional control.
Okay. And you break these down into different types.
We do. Broadly, there are three categories. First is the situational crisis. Think of this as the unexpected external shock.
Like getting laid off or a sudden serious diagnosis.
Precisely. Or a major loss.
Yeah.
It comes from outside, disrupts things badly, but it's usually tied to that specific event and tends to be shorter term.
Okay, that makes sense. What's next?
Next up is the maturational crisis.
Yeah.
This one is interesting because it's tied to, well, normal life changes, developmental stages.
Oh, like adolescence, or maybe starting college, or even retirement, stuff we kind of
Right,
expect.
exactly. Predictable transitions, but they still demand a huge shift in how we cope, how we see ourselves. They can definitely throw someone into crisis.
And the third type sounds intense, adventitious crisis.
It is. These are the big, unplanned, often traumatic events. Things way outside of normal daily life. Natural disasters, terrorist attacks, community violence, things that can impact whole groups of people.
Wow. Okay, so regardless of which type it is, there's a pattern to how people react psychologically, like phases.
Yes, our sources map out 4 phases, basically tracking how anxiety escalates. Phase 1, the initial impact. Anxiety spikes, and you immediately pull out your usual defenses, hoping they'll work.
Standard coping mechanisms first.
Right. But if those fail, if the stressor continues, you hit phase 2. Anxiety keeps climbing, and your ability to function gets disorganized. You start trying anything, that sort of trial and error scramble for a solution.
Stressful.
Very. And if that doesn't work either, phase 3 kicks in.
Yeah.
This is where anxiety can escalate to full-blown panic, that fight-or-flight response. You might desperately try to compromise or find any way out to just make the feeling stop.
And if you can't, if nothing works,
Then you reach phase 4. If new coping skills don't emerge, or the situation isn't resolved, it becomes a mental health emergency. The system is overwhelmed.
okay, so when we talk about crisis intervention, it's not long-term therapy, is it?
No, absolutely not. That's critical to understand. It's specifically short-term, usually just a few weeks.
And the goal is?
It's focused.
Mhm.
Reestablish some psychological balance, some equilibrium, help the person regain that feeling of control they lost, and ideally get them back to functioning at least as well as they were before the crisis hit.
Got it. So when you're assessing someone in that state, what's the first thing you look for?
Safety. Always safety. Before you even dig into their perception of the event or their support systems or what coping skills they do have, the absolute #1 priority is assessing for any risk of harm to self or others, suicidal or homicidal thoughts.
Stabilize first, understand later.
You have to. It's the bedrock.
Okay, so that's the external picture of crisis. But to really understand how to help, we need to go inside, right, into the brain.
Exactly. Because mental disorders, fundamentally, are disorders of the brain. The sources are very clear on this. They involve disturbances in how we think, feel, behave, even our basic bodily functions. And it all ties back to disturbances in the brain's chemical signaling.
The brain is the command center.
Pretty much. It manages everything, keeping the body stable, hormones, consciousness, memory. And we look inside, there are a few areas especially relevant to mental health.
Like the limbic system. I remember that being linked to emotions.
Chiefly. It's central for regulating emotional behavior, but also learning and memory. Trauma processing often involves the limbic system heavily.
Okay, and the hypothalamus. That's more basic functions.
Right. It regulates the autonomic nervous system. Think involuntary stuff like heart rate, breathing, plus hormones, and those core drives like hunger, thirst, body temperature. Problems here can show up as very physical symptoms.
And for the things we associate more with complex mental health issues, like judgment or personality.
That brings us to the lobes, particularly the frontal lobe. That's our executive control center. Judgment, planning, personality expression, regulating emotions. It's crucial. Difficulties with impulse control or decision-making often point to frontal lobe function.
So how does the brain actually send messages about all this stuff?
Through neurotransmitters. Think of them as specific chemical messengers, each with a different job. For mental illness and medication, there are, well, maybe 4 really key players we need to talk about.
Okay, let's hear them.
First, serotonin. Probably the most famous one, often linked to mood, but it also strongly influences sleep, arousal levels, appetite.
And disruptions are linked to depression, anxiety.
Definitely. Then there's norepinephrine. This one's more like the accelerator. It governs alertness, focus, consciousness, and kicks in that fight-or-flight stress response.
Got it. And dopamine.
Dopamine is mostly excitatory. It's vital for movement, but also for integrating our emotions and thoughts, decision-making, and it plays a big role in the brain's reward system. Motivation, pleasure.
Okay, excitatory. So what's the main break?
That would be GABA. Gamma-aminobutyric acid. It's the major inhibitory neurotransmitter. Its job is to slow down nerve activity, promote calmness, relaxation.
Like a natural tranquilizer.
In a sense, yes.
So when these neurotransmitters get out of whack, too much, too little, maybe the receptors aren't working right? That's when we see the symptoms that we then classify.
Exactly. Like in schizophrenia, you might see disorganized thinking and speech, problems with learning, alongside hallucinations or delusions that points to complex neurotransmitter disruptions, particularly involving dopamine.
Or in depression, those changes in appetite and sleep, the trouble concentrating.
Often linked to serotonin and norepinephrine systems, yeah. Mania, with decreased sleep, racing thoughts, rapid speech. That involves several systems, including dopamine and norepinephrine.
And we use the DSM-5 to categorize these patterns.
Correct. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition. Our sources mention it organizes diagnoses into 20 major categories, and it does so on a kind of developmental timeline, from infancy through older adulthood. It's the shared language, the dictionary, that helps clinicians communicate clearly about specific conditions.
Okay, so if these are brain disorders linked to chemistry, then the tools we use have to target that chemistry. Let's talk psychotropic medications. Antipsychotics first. There's been a big shift there, hasn't there? From the older typicals to the atypicals.
The huge shift. The typical or first-generation antipsychotics were real game changers when they arrived. They are strong antagonist blockers, primarily of the dopamine D2 receptors.
And they worked well.
For the positive symptoms, things like hallucinations, delusions, disorganized thinking, the symptoms that are actively present, they were very effective there.
But they came with significant downsides, right? Side effects.
Big ones. By blocking dopamine so strongly, they often cause serious movement problems, collectively called extrapyramidal symptoms, or EPS.
Like Parkinson's symptoms.
Sure.
Muscle stiffness.
Exactly. Parkinsonism, acute dystonia, painful muscle spasms, akathisia, which is that awful inner restlessness. And the really worrying long-term risk was tardive dyskinesia, or TD.
TD. Those are the involuntary movements, sometimes in the face, tongue.
Yes, and they can be permanent, even after stopping the medication. So the risk was substantial.
Which led to the development of the newer drugs.
Precisely. The atypical, or second-generation antipsychotics. These were a major advance because they work differently. They still block dopamine, but usually less intensely, and they also block certain serotonin receptors.
And that dual action makes a difference.
A huge difference. It means they can often treat the negative symptoms too, things like apathy, flat affect, social withdrawal, lack of motivation, which the older drugs didn't touch much. And crucially, they generally have a much lower risk of causing those severe EPS and TD.
Okay, lower risk of movement problems. But there's always a trade-off, isn't there? What's the main concern with the atypicals?
The big one is metabolic effects. This is a major focus now.
Metabolic, meaning effects on the body's energy processing.
Exactly. We're talking significant potential for weight gain, sometimes quite rapid. And that increases the risk for developing type 2 diabetes, high cholesterol, high triglycerides, basically cardiovascular risk factors.
So you trade movement risks for metabolic risks, in a way.
It's often framed that way, yes. It means monitoring physical health, weight, blood sugar, lipids becomes just as important as monitoring mental health symptoms.
Managing these meds sounds complex. And our sources highlighted a couple of really dangerous acute emergencies people need to know about. First, neuroleptic malignant syndrome, or NMS.
NMS. It's rare, thankfully, but potentially fatal. It usually happens early in treatment, maybe within the first month.
And what does it look like?
It's a specific cluster. High fever, severe muscle rigidity, sometimes called lead pipe rigidity confusion, or altered mental status, and autonomic instability. That means vital signs go haywire. Unstable blood pressure, rapid heart rate, sweating.
And the responses.
Stop the antipsychotic immediately. This is a medical emergency requiring intensive care.
Okay, critical warning there. And there was another specific risk mentioned for one drug, clozapine.
Yes, clozapine is a highly effective atypical, often used when others fail. But it carries a unique, serious risk. A granulocytosis.
Which means?
A potentially catastrophic drop in white blood cells, specifically neutrophils, which fight infection. It essentially wipes out the immune system.
Wow. How do you manage that?
Strict, mandatory blood monitoring. Regular CBCs complete blood counts, often weekly at first, then maybe biweekly or monthly if stable. It's non-negotiable. The risk requires constant vigilance.
Understood. Okay, let's shift gears to antidepressants. The main ones used now are the SSRIs, right? Selective serotonin reuptake inhibitors.
Yes, they're generally the first-line choice for depression and many anxiety disorders. They work, as the name suggests, by blocking the reuptake or recycling of serotonin back into the nerve cell that released it.
Leaving more serotonin available in the synapse, the gap between nerve cells.
Exactly, boosting serotonin signaling.
What's the key thing patients need to know when starting an SSRI?
Patience, that's the big one. These drugs don't provide instant relief. It typically takes several weeks, often 4 to 6 weeks, sometimes longer, to feel the full therapeutic benefit. The brain needs time to adapt. Managing that expectation is crucial.
Okay. And just like NMS with antipsychotics, is there an acute risk with SSRIs? I think our sources mentioned serotonin syndrome.
Yes, SSS. It's caused by excessive serotonin activity in the central nervous system. Often happens when combining multiple drugs that boost serotonin, like 2 different antidepressants, or an antidepressant with certain pain meds, or even some supplements like St. John's wort.
And what are the warning signs? How do you recognize it?
Clinicians look for a characteristic triad. First, changes in mental status, confusion, agitation, restlessness. Second, autonomic instability, fast heart rate, sweating, maybe fever, fluctuations in blood pressure. And third, neuromuscular abnormalities, things like muscle twitching, tremors, hyperreflexia, maybe even rigidity.
Yeah, another medical emergency then.
Absolutely. Stop the offending agents immediately.
We should also quickly touch on the older antidepressant classes because they still have a place but carry bigger risks. The tricyclics, TCAs.
Right. Effective drugs, but they have a major drawback.
Yeah.
They're very dangerous in overdoses. Even a relatively small overdose can be fatal due to cardiac toxicity effects on the heart rhythm and neurotoxicity. Much less safe than SSRIs in that regard.
And the MAOIs, monoamine oxidase inhibitors.
Another older class, also effective, but notorious for their dietary restrictions. They inhibit an enzyme that breaks down tyramine, a substance found in certain foods.
What kind of foods?
Aged cheeses, cured or smoked meat, certain fermented foods, some beers and wines. If someone on an MAOI eats these tyramine-rich foods, they can experience a sudden, severe spike in blood pressure called a hypertensive crisis. Life-threatening.
So strict diet is essential. Got it. 2 more quick classes to hit. Benzodiazepines for anxiety.
Benzos, yes. Think Valium, Xanax, Ativan. They work by enhancing the effect of GABA, our main inhibitory neurotransmitter.
The brake pedal again.
Exactly. They boost GABA's calming effect, reducing anxiety quite rapidly. Very effective for short-term relief, like during a panic attack or acute stress.
But the big warning sign here is
Addiction potential. They are highly habit-forming, and tolerance develops, meaning you need more for the same effect. Withdrawal can also be severe, even dangerous. So they're generally intended for short-term or intermittent use, not typically as a long-term primary treatment.
right. Highly addictive key takeaway. And finally, the mood stabilizer cornerstone, lithium. Primarily for bipolar disorder, what's the absolute must-know?
The narrow therapeutic range, this is critical. The difference between a dose that helps stabilize mood and a dose that causes serious toxicity is incredibly small.
How small are we talking?
The therapeutic blood level is generally considered to be between 0.6 and 1.0, maybe up to 1.2 milliQL. Levels just slightly above that can start causing side effects, and levels approaching 2.0 mil or higher can lead to severe toxicity.
Toxicity, like what? What are the signs?
Early signs might be increased tremor, maybe some nausea or diarrhea. As it gets worse, you see things like a coarse hand tremor, significant slurred speech, confusion, drowsiness, muscle twitching. At very high levels, it can cause seizures, coma, kidney damage, and even death.
So constant blood level monitoring is essential.
Absolutely essential. And patients need to be educated about factors that can affect lithium levels, like dehydration, changes in salt intake, or interactions with common medications like NSAIDs or diuretics.
Wow. Okay. We've covered the crisis, the brain chemistry, the meds. Let's wrap up by looking at the bigger picture, the philosophy of care. There's been a real shift, hasn't there, from what used to be called rehabilitation to this idea of recovery.
A massive shift. Historically, especially in the era of large institutions, the focus was very much on rehabilitation, meaning the primary goal was often seen as managing the deficits caused by the illness, trying to restore basic functioning, maybe control symptoms, aiming for some kind of cure or containment, and the goals were often set by the clinicians. You need to take your meds, you need to keep your room clean.
Okay. How does the recovery model differ?
It's a fundamentally different philosophy. Recovery, in this sense, doesn't necessarily mean cure. It acknowledges that symptoms might persist, sometimes lifelong. The focus shifts to supporting the individual in defining and pursuing their own goals for a meaningful life, whatever that looks like to them.
Even if they still experience symptoms.
Yes, it's about building a satisfying, hopeful, and contributing life despite the challenges of the illness. It emphasizes personal empowerment, self-determination, hope, and integration into the community on the person's own terms.
So it moves the control back to the individual.
Completely. It asks, what do you want your life to look like? And how can we support you in getting there, rather than how can we fix you so you sit back in? It's a much more person-centered, hopeful approach.
But achieving that, especially for people with serious mental illness, SMI, it faces huge hurdles, doesn't it?
Immense hurdles. Our sources point to so many obstacles. Externally, there's the relentless stigma and discrimination they face in housing, employment, social relationships. There's isolation, economic hardship, often co-occurring physical health problems.
And internal challenges, too,
Yeah.
related to the illness itself.
Yes. One major challenge is something called anosognosia.
Yeah.
It's often described as poor insight, but it's more complex than that.
How so?
It's thought to be a neurological symptom, where the illness itself actually damages the part of the brain, often the frontal lobe again, that's responsible for self-awareness, and recognizing that one is ill. It's not denial in the psychological sense. It's an inability to perceive the illness.
That's profound. If you can't recognize you're ill because of the illness itself.
It makes treatment, adherence, engagement, and pursuing recovery incredibly difficult. It's a huge barrier.
Okay. This has been quite the deep dive. We went from the chaos of an acute crisis and the absolute need for safety, down into the brain's wiring, tracing how neurotransmitters like serotonin and dopamine and GABA run the show.
Right.
Then navigated the landscape of psych meds, understanding the benefits, but also the critical warnings like NMS, serotonin syndrome, the risks with lithium.
The necessary tools, but ones that need careful handling.
Exactly. And we finished with this really important shift towards the recovery philosophy, empowering individuals to build their own meaningful lives.
It really highlights how effective support requires understanding all these layers, the biology, the pharmacology, the immediate crisis needs, and the long-term personal goals and values.
Yeah.
It's integrating the science with the human spirit.
A powerful synthesis.
Indeed. But maybe here's a final thought for you, our listener, to mull over. Connecting back to that idea of recovery. We've talked about this modern emphasis on empowerment, on supporting people to define and build their own meaningful lives. So how does that pervasive, constant challenge of stigma, that external barrier people with SMI face every single day, how does it actively undermine the very possibility of achieving those personalized recovery goals and finding true acceptance and integration within the community? It really puts the philosophy up against a harsh reality.